friends. This evening we are going to talk about a long topic, acute limb ischemia. I hope I should be able to finish it today, and if we cannot, then we will put an interval in between and discuss it on the next time, whatever is left. Now, for young surgeons, there are some definitions which I would like them to write. Acute limb ischemia is defined as sudden decrease in limb perfusion causing a potential threat to the limb viability. This is acute limb ischemia. Then critical limb ischemia. The internationally accepted definition is any patient with chronic ischemic rest pains, ulcers or gangrene attributable to objectively proven arterial obstructive cause is critical limb ischemia. There is another definition. CLI is also defined as resting limb pains with impending loss of limb due to severe vascular compromise. Whatever definition you take, they convey the same things. So I've told you two definitions. Three more. These are usual bedside questions, and if you don't do well on this, there is a lot of danger to your exam result. Define gangrene. Gangrene is death of a part of body secondary to decrease vascular supply. So a gangrene has to be, number one, death, number two, a part, number three, due to vascular supply. Fourth definition, dry gangrene. Please keep noting, these are the pearls, this is a condensed material from several books. Define dry gangrene. Gradual arterial obstruction, welcome Ankit, free from edema. Gradual arterial obstruction, free from edema, drained by open veins, exposed to evaporation, protected from infection, has sensory loss. The part is dry, wrinkled and shriveled, and there is a clear line of demarcation. I will repeat this. Dry gangrene is defined as gradual arterial obstruction, free from edema, drained by open veins, exposed to evaporation, protracted from infection, has loss of sensation, the part is dry, wrinkled and shriveled. And there is a clear line of demarcation. Now the wet gangrene. Wet gangrene is the result of sudden arterial obstruction in a limb which has tissue edema and venous stasis. It can happen in a healthy limb when there is sudden arterial blockage which avoids the loss of evaporation. Of the tissue fluids. Tissues are inflamed, edematous and infected. So friends, I have told 5 definitions to begin with: acute limb ischemia, critical limb ischemia, gangrene, wet gangrene, dry gangrene. If you will tell in exam the definition of dry gangrene as I have told you, you get 10 out of 10 and the case will finish only on definition. No further viva will happen. Now let us discuss the topic. Acute limb ischemia occurs when there is either an embolus or a thrombus or occlusion of a bypass graft. The severity depends upon duration, degree of occlusion, partial or complete, collaterals. What are our aim and objective? What are our goals of management? Number 1, we want to save the limb. Number 2, we want to minimize the morbidity. And number 3, we want to prevent death. So I repeat: limb salvage, minimum mortality, morbidity, and to prevent death. But still, in 1970, the mortality was 26% and amputation rate was 37%. Today, 50 years later, the mortality is 15% and the amputation rate is 10 to 30%. The amputation rate and the mortality has come down because of better understanding of the disease process, good facilities of imaging, interventional radiology, and better understanding of associated comorbidities. These people, they die of comorbidities, not the amputation. The history is sudden pain in embolic and gradual increasing pain in thrombotic, which the episodes first are milder nature in thrombotic, gradually the claudication distance decreases and eventually a thrombosis occurs. We need to know the functional status of limb before ALI happened. Detailed history of previous endovascular bypass or grafts, MI, arrhythmias, failure, atrial fibrillation, and valvular disease is important for embolic phenomena. Similarly, hypertension, dyslipidemia, and smoking is an important predisposer through thrombotic process. We need to know if the patient already suffered from some motor disease process. Now, few things about the 6 P's of acute limb ischemia. I will only raise the relevant points for postgraduate level. First P is pulse. Palpated compared with the previous documentation, if any. Pulse with a fresh clot may be palpable, though the distal pulses will be absent. For example, in a fresh popliteal thrombus, still popliteal may be palpable, though the distal pulses may not be palpable. Pain is severity matching the severity of ischemia. But as the pain increases, it is replaced by anesthesia, because when the occlusion is complete, the nerves are the first to suffer the effect of ischemia, and hence a patient who had very, very severe pain, suddenly the pain stopped. There are two things. Either the umbilus got dislodged, then feel for the pulses, or the limb is getting gangrenous, the nerves are dying, so then there is anesthesia. Pain has to be documented in severity, localization, and progress. The rest pain limited to the foot is pathognomonic of critical limb ischemia. ALI involves the diffuse vessels all along the limb. In United States, 50% of patients with limb ischemia have been in one series referred to neurologist for the limb pain. Pallor is the third sign, followed by cyanosis. Pallor is due to complete emptying and vasospasm. Molting appears later and which blanches on pressure. If in a patient of ALI, capillary fill is there, that indicates the limb may be retrievable. If the collaterals develops, the pallor will be followed by refill within 6 to 12 hours. A word about poikilothermia may increase the ischemic cascade via vasoconstriction, and the level of coolness and the pallor is well level below the arterial occlusion. Paresthesia is essential. It is the earliest sign. Now the younger surgeons should note down that loss of small myelinated fibers occurs first. Small myelinated fibers which carry sense of fine touch, 2-point discrimination and vibration, and larger fibers are responsible for temperature, pain and pressure. They die off subsequently. Paralysis. In advanced ALI, paralysis is the feature. Now, paralysis occurs segment-wise. When it is the intrinsic muscles of the foot, that means vessels around ankle are involved. in popliteal and superficial femoral artery thrombosis, the dorsiflexors and plantar flexors are involved. If motor function of the limb is gone, then limb is gone. There is no need of any further investigations. Grading of ALI, acute limb ischemia. Grossly, welcome Dr. Jain. It is either a viable limb or a threatened limb. Threatened is divided into marginally threatened and immediately threatened. Or it is irreversible, which cannot be reversed back whatever you do. Based on the sensory motor combination of ankle arterial signals and the venous Doppler, the severity is decided. So is the need of intervention. Type 1 is acute obstruction in a vessel which is chronically obstructed, hence has collaterals with it. So there is no threatening to the limb urgently. Type 2A is threatened but salvageable if timely intervention is taken. And 2B is threatened, which needs immediate embolectomy. And type 3 is irreversible ischemia and amputation is needed. Now, what are the investigations for ALI? First, we have to do complete cardiac workup for embolus. Then thrombophilia profile means anticardiolipin, antiplatelet factor, and homocysteine and familial thrombotic events. Objective evaluation of arterial tree. Doppler, segmental arterial Doppler, pressure studies, ankle brachial index. Now, since the topic is very long, ABI I will leave for the residents as their homework. Doppler studies can show, number 1, localized obstruction. Number 2, tell us the status of graft or the bypass or stent. In a stented vessel, we can also know stenosis, plaque morphology, dissections and thrombi. Arteriography is performed in emergency situations in angiosuit, where if on arteriography we need to decide in favor of an intervention, we should be able to do. If we think we are going to do open surgery, we should be able to do. And if you plan for thrombolysis, then we can do. So all the things, modalities should be available in angiosuit in one place. DSA has an advantage that less contrast is used. And all collaterals can be seen well. In patients whom we want to do angiography and have drug allergy or rise urea creatinine, we can do carbon dioxide or gadolinium arteriography. This we have talked earlier also. Now, for the exam going candidates, some DD between embolus and thrombus is usually asked. In embolus, you can find a cause 90% of the time. Thrombus, there is no cause. The cutoff is sharp in embolus. In thrombus, it is a tapering sort of diffuse disease. Evidence of atherosclerosis is minimum in embolus and there is a diffuse atherosclerosis in thrombus. Few collaterals because embolus forms a sudden disease process. And thrombus has usually definite collaterals. Distal artery may look small due to spasm in embolus, but is normal. In thrombus, the whole artery is disease processed. Thrombus usually lodges at the bifurcation. Embolus lodges at bifurcation, and thrombus is the site of chronic atherosclerotic disease. We have role of CT angiography and MR angiography. All the pros and cons we have discussed every day. So today we will not discuss what are the advantages of CTA and MRA. What is the journal management? Earliest reperfusion is the key. First point is, as soon as you see the patient, systemic heparin is the key. The limb should be dependent and avoid pressures. The limb should neither be made very cold. There was a previous concept, as soon as you get a ischemic limb, cool it down to decrease the oxygen demand. But currently it is thought that cooling too much produces vasoconstriction. And if the limb is heated up, the tissue demands of oxygen go up. So leave the temperature in a balanced way. It should be cool, not hot, but not ice cool. Increase the tissue oxygenation by, number one, increased intravascular compartment by normal saline. Correct the cardiac output. If there is a deficit, correct the cardiac output. If patient is anemic, correct the transfusion to correct the oxygen capacity, and give by face mask oxygen more than 20 to 30%. Now, in this, we need to know everything about coagulation casket, which is also your homework. Anticoagulation, I will say a few words. Heparin decreases mortality, decreases morbidity, and it increases the limb salvage. It also decreases the propagation of thrombus. It decreases the additional load of emboli. Unfractionated heparin, 80 to 90 units per kg stat and 15 units per kg IV per hour, till APT is 2 times. Now you are supposed to know as your homework the mechanism of action of heparin and the side effects. There are 2 important side effects. Heparin induced thrombocytopenia type 1 and type 2, which you need to read. Thrombolysis. Now, what about thrombolysis? First thrombolysis was done in 1970 by Dr. he popularized plasminogen activators, which produce cleavage of peptide bound between plasminogen and convert into plasmin. And then plasmin affects the fibrin polymer and leads to thrombus dissolution. There are three kinds of thrombolytics available in the market. You should know at least one line about each. If I tell you 4 lines, remember one line. I will tell you what is that one line for you. Streptokinase, derived from streptococcus, acts at dual site. You don't need to remember the site, but can have antibody reaction if somebody is exposed to it earlier. The second time the patient can have severe reaction. So that is all what you need to know. Streptokinase is the first thrombolytic agent. It is cheap, it has double action, and it has reaction if previously exposed. Urokinase, mechanisms of all that are the same. They activate plasminogen to affect the plasmin, and plasmin affects the fibrin polymer. Now, plasminogen is extracted from human neonatal kidney cells or murine hydranoma cell alive. Third is TPA, tissue plasmin activator. This is the latest. This is produced by epithelial cells, increased specificity to fibrin. When you give TPA, tissue plasmin activator, it affects the fibrin more. You can, if remember, there are 3 names: atiplase, dutaplase, and tenecteplase. The advantage is tenecteplase requires only single dose. Catheter-induced thrombolysis is better than intravenous thrombolysis. Some basic facts about thrombolysis. Thrombolytic treatment, first point, thrombolytic treatment is an effective initial therapy for acute arterial occlusion with no sensory motor deficit. Number 2, it is not for common femoral embolus, which should be dealt surgically, and also those who have sensory motor defect and no distal runoff. It is useful for a occluded graft where catheter thrombolysis may be possible. Fourth point, the femoropopliteal bypass grafts have associated stenosis with them. So doing thrombolysis will be a temporary stopgap arrangement. Treatment of stenosis is primary to prevent another episode of occlusion. Possibly, the puncture for thrombolysis should be away from the site of thrombus, because to prevent the catheter related complications and rebleeds. For example, if you have to do a common femoral thrombolysis, then the catheter is passed from the contralateral side, gone up through the aorta, back, and embolize the embolus or thrombolysis is done in the common femoral artery. Now a guide wire is passed distal to the clot. Do a flush angiogram and then inject thrombolytic agent. If the catheter cannot pass, then thrombolysis will not be effective. Next point is mechanical thrombus removal. With or without pulse sprayed initially, followed by continuous thrombolysis. Heparin is added when there is a sheath in the artery to prevent pericatheteral thrombosis. And check that fibrinogen is more than 100 mg per liter. All successful thrombolysis have to be followed by a definitive endovascular or an open treatment. Thrombolysis is to buy time. Thrombolysis is to save the muscle. The disadvantage is the cannula in situ for 20 hours. There can be risk of major bleeding, thromboembolic complications. End point of thrombolysis is either the flow is adequate and the thrombus is resolved, or there are no changes and there is occlusion or a catheter side bleeding. Now, if thrombolysis fails, then what else we can do? The next point is thrombectomy. Now, there are minimal access modalities of doing thrombectomy. Number one, percutaneous thrombectomy. In a fresh thrombus, a catheter can be passed next to the clot and clot is aspirated, thereby decreasing the thrombus load and requiring less dose of thrombolytic therapy. Second is percutaneous mechanical thrombectomy. This is a hydrodynamic process in which a catheter is passed with the jet, saline jet, the thrombus is broken, and from the side holes the debris is sucked out. Technique has 95% limb salvage rate. Adjuvant thrombolytic therapy was given in more than half the patients. Disadvantage, there is a large load of thrombus debris which can lead to further emboli distal in the limb. Then the third point is ultrasound based thrombectomy. It is a pulse wave, low power, high frequency, which alters the fibrin composition. So with the ultrasound wave you break the thrombus and then it is followed by catheter induced thrombolysis. Leads to around 80% of patency. If these two methods fail, then the last resort is surgery. Surgical embolectomy is usually done under local for common superficial and deep femoral vessels. Now remember, wherever in vascular surgery, first principle, if you can manage with a transverse arteriotomy, answer is always transverse arteriotomy. If you have made a vertical arteriotomy, well, the examiner may not ask you such details till you keep answering him one after the other, one after the other. Like this class goes on. If you vomit like this to the examiner, then this turn will come. If you do a longitudinal arteriotomy, when you close it, it leads to narrowing. Hence, all longitudinal arteriotomy will be covered by a vein patch. Imagine this is the vessel, you've done arteriotomy, this is the open arteriotomy. If you try to suture, it will become narrow. So what you do? You put a vein patch like this. Take a saphenous vein, slit it open, divide to the size and put a running suture or interrupted suture, and the vein will remain or artery will remain open. In 3 to 4 weeks time, the vein will start behaving like artery. So, after doing arteriotomy, you can remove the embolus up and down, and eventually when you have cleared everything, do a completion angiogram to see clots, residual or any stenosis. Popliteal embolus, when you want to remove, you make a vertical arteriotomy and extend it over interior tibial. Once you have cleared everything, put a vein patch. And such patients are given local heparin 5 to 7,000 unit in the vessel, and they are given systemic heparin and warfarin to follow for 6 months to prevent rethrombosis. Now, another term not commonly discussed, I would like to bring to your notice. Atheromatous embolization. Microcholesterol-laden debris which travels from a proximal large vessel to a distal small vessel, usually from an unstable plaque or an aneurysmal sac, an aortic aneurysm or atheromatous plaque in the aorta which is unstable. Such things are associated with all other atherosclerotic diseases like MI, stroke, ARF, cutaneous ischemic manifestations, vascular and cardiac operations, and previous angiographic attempts. Remember, if both lower limbs are involved, the cause is in the aorta, and if one is involved, the cause is in the iliacs or common femoral. There is a term which you may be asked is called livedo reticularis. This is not specific to atheromatous embolization. This also happens in acyl and cryoglobinuria. It is due to, please, this you write down, livedo reticularis. This is due to delayed venous drainage due to blockage of capillaries of venules in small arteries. An intra-arterial catheter or clamping of aorta can lead to rupture of the plaques and produce such a picture. In such situation, the investigations are segmental Doppler pressure studies, duplex ultrasound to diagnose what we have already discussed. Aortography is only if everything else fails. What is the aim? Number one, to treat the end organs Number two, to prevent such episodes again, all such patients should be put on dual antiplatelet, statins, lifestyle management, control of diabetes, leaving the smoking, exercise, weight reduction. I would like all my residents here to able to vomit out the modifiable and non-modifiable risk factors of PVD. PVD exam is held with us 4 times every day. Every single patient is our examiner, and it should be on your fingertips. What are the non-modifiable factors? What are the modifiable? When you practice them every day, then you are not scared of examiner. And the senior faculty can also tighten them up, that when they write a case sheet for PVD, they should write all the factors. If even they see 3 patients in one day, they should write for all 3. Writing is the best way to imprint on your brain. The causes in the upper limb are usually thoracic outlet syndrome, and which is managed by the standard techniques. Aorta, if that is the cause, or emboli from iliacs is the cause, they are treated with covered stents. And if it is popliteal, then it is ligation of popliteal and a FOMPAP or tibial bypass. Now, we have time. So, what is the pathophysiology? Pathophysiology is ALI begins with emboli, thrombus, or trauma. Occlusion of the artery, suddenly, if it is a gradual, then the collaterals develop. If it is a sudden, there are acute symptoms. The magnitude is parallel to the duration of ischemia and the amount of tissue affected. Skin and bone are the last affected. Nerves earliest affected. But the effect of the death of the muscle mass produces maximum damage. What happens in ALI? The aerobic muscle metabolism is converted into anaerobic metabolism. There is increased production of lactate and profound metabolic acidosis. That leads to dysfunction of calcium and sodium exchangers, leads to increased calcium level in myocytes, which interact with the muscle, leading to myonecrosis. This is the pathophysiology, how the death of muscle occurs. I repeat, mechanism for muscle change from aerobic to anaerobic, increased lactate, increased perfusion, metabolic acidosis, dysfunction of calcium sodium channels, and increased calcium levels in myocytes, which gradually lead to death of the myocyte. Then hypoperfusion and reperfusion. Friends, hypoxia kills the muscle. Remember this dialogue for your lifetime. Hypoxia kills the muscle. Reperfusion kills the man. So, when there is reperfusion or high risk of reperfusion, better to lose the limb than life. That is the message. Now, what happens? When there is decreased blood oxygen supply, the movement of blood across the vessel decreases, the thrombus further grows and propagates, even occluding the collaterals. The ischemic cells swell and retain water. The swollen cell mass together increases compartment syndrome. The compartmental pressure leads to further decrease in blood flow. Then precapillary arteriolar walls swell. Leading to decreased lumen of distal arterioles and venules, which further decrease the flow. Reperfusion has systemic effects, increases morbidity and mortality. During reperfusion, highly active oxygen metabolites produced by neutrophils lead to free radicals which destroy unsaturated bonds of fatty acids in phospholipid membrane. This you have to read once again. Which leads to disintegration of the cell membrane. There is increased CPK, there is increased bioglobinuria. So, the changes which occur, lot of toxic oxygen metabolites are released, which leads to acidosis, hyperkalemia, myoglobinuria, acute renal failure, myocardial depression, arrhythmias, and decreased vascular tone leading to shock. And this is what kills the person. There are any questions? Please put it now. That comes to end of acute limb ischemia. And all questions are welcome, please. And if you have a later thought, you can always put the question again and I will answer that. Constant teaching over the last 4 weeks on the Facebook as well as with the resident has led to change of my voice. So today my ENT guy advised me vocal rest for a couple of days. So maybe for next 2-3 days I will not be able to be here at 9:30. Bear with me. Once I am fit and better to speak, I shall be back. Thank you so much for being with me. Have safe life, wash your hands, keep your distance, and take care of your family and friends. I am your well-wisher. Have a good night's sleep. Bye.